We are recording, and I think we're live.
Okay.
Good evening, everybody out there, and welcome to our second edition of Facebook Live. The Endometriosis Summit is held each March in Hoboken, New Jersey, and this week we bring to you Dr. Dulemba, an excision specialist and endometriosis activist extraordinaire from Texas, and of course our Endometriosis Summit co-founder, Dr. Andrea Vidali, who has taken a short break from the OR in New Jersey and New York. Okay, I'm gonna let Dr. Vidali kick it off while I pop on over to Facebook and see if we have any questions just yet.
Good evening, Dr. Dulemba and Sally.
Thank you. Good evening.
And welcome. We're all excited about the upcoming Endometriosis Summit. And actually, I would like to let people know that we're almost half sold out, right? Am I right, Sally? Or like pretty close to that, right?
I would say we are sold out. Endometriosis Summit workshop, that's sold out in under a week. That's our Saturday event.
Wow.
And our Sunday town meeting, our patient and practitioner town meeting, where we're waiting to hear from all of you, is about 40% sold. We do expect to sell out, so buy your ticket. And then today, Dr. Vidali worked with Luminous on preparing for our live surgery, which you will be able to watch from home.
So we're really excited about all these options. So make sure you get your tickets for the summit. I think it's important that you do it now rather than later, because you may not be able to get in if you wait too long.
I agree.
If you do come, you'll get to meet Dr. Dulemba in person. He was there last year. A surgeon extraordinaire, really, and really one of the a legend, really, in the world of endometriosis. Somebody who's been doing it for a very long time and doing it right out there in Texas. And I think somebody who has pioneered certain concepts, certain ideas. I think if I should mention a couple, one of them is you were really the first ones, and I followed, but you were the first ones to start testing the receptors, hormonal receptors on endometriosis, right? And as well as, the concept of adhesions that we talked a little bit later. But perhaps, I don't know, Sally, shall we start talking about the receptors a little bit?
Right, let's talk about the receptors. So, Dr. Dulemba, could you explain to us what you think is going on at the receptor and why you test for them? Because lots of people don't understand why we would need pathology to test at all.
Okay, well, to begin with, some of this started over 17 years ago when a study came out looking at breast cancer, the WHI, the Women's Health Initiative. And when I saw that some of the results from that, it triggered a thought in my mind, and a friend of mine, Dr. Jeremy, or Mr. Jeremy Wright, because over in the UK, they call them Mr. when they're surgeons. But he came up with the concept of why don't we check for receptors, and then he stopped. And I continued. But the reason I did it is when somebody has breast cancer and they cut out the specimen, they send it for receptors. Of course, they check for the HERS too, but they also check for estrogen and progesterone receptors. And, certainly there's certain misconceptions and conceptions about breast cancer, but it turns out that 65% of breast cancers are positive for both estrogen and progesterone. So when I saw that, and for what my friend Jeremy Wright had mentioned, I said, you know what? I think I need to start checking receptors instead of just blaming estrogen, which we've done for over 100 years. Instead of just doing that, why don't we find out what is actually potentially in that cell causing endometriosis to grow? I can't prove that, but all I can do is check and see what receptors are there. What's fascinating is during this last 15 years that I've been doing this, 75% of the specimens that I cut out are positive for both estrogen and progesterone. The next most common number of receptors are progesterone. Rarely, and I see maybe 1 or 2 specimens a year positive for only estrogen. Now, I've been asked the question, what does that mean on the cellular level? And I'm like, we need scientists to figure that out. But I query back, what happens with estrogen? And we don't know for sure. Some doctors say, well, it's only estrogen, and progesterone may have other properties for it. But at least I have a concept of what's going on. One of my pathologists also pointed out that they check for the intensity to the hormone, to the receptor. And either they're equal or progesterone seems to be greater in intensity. I asked the pathologist, what did that mean? And they went, I don't know. But from what I understand is that in the intensity may be how it responds to the cell. Now, 2 years ago, out of Belgium, there was a study on 41 patients, prospective, that found different receptors in different areas in the same patient. And that's exactly what I found. Some other things that I found over these 15 years is that it seems in the younger patients, I see a preponderance of progesterone receptors. Rarely, and then both. But and as the disease seems to progress, then it seems like when it's on the diaphragm, when it's all over the place, that it's almost always both when the disease is more advanced. I can't give an explanation on why, but all I know is if we continue to just say estrogen, then what it's going to do is, why aren't our patients better when we eliminate estrogen? So that's what I do and why I do it. It's not estrogen levels in their hormones, it's the receptors in the disease. And I also check more than just endometriosis. We check for fibroblast mesothelial cells, glands, stroma, and endometriosis, 5 cell lines.
Well, I would argue, John, that it's possible, at least for the endometrium, that, well, first of all, it's a heterogeneous disease, right? Not every endometriosis lesion looks the same.
Exactly.
Not every endometriosis behaves the same.
Correct.
We see lesions that are, white lesions, red lesions, black lesions.
Right.
We see
clear,
people
yellow.
with endometriosis. We see people with deep invasive endometriosis. We see people with superficial endometriosis.
Right.
So it is obviously a heterogeneous disease. So
right.
I would say I would be surprised if it, from a receptor standpoint, if it would all be the same, because it behaves differently.
Right.
So it's heterogeneous, and its behavior probably depends on different factors. One is the host being the patient, right?
Yes.
And the second one being the genetics of the disease, which,
right.
May originate in different parts of the pelvis, deeper and more superficial. So that's one part of it, which kind of makes a lot of sense with me, that it wouldn't always be the same. And I think, and Sal, you can interject at any time, of course. Sorry if I just kind of took the lead in this. And the second thing is, I think progesterone usually, at least for what pertains regular endometrium. We know endometriosis is not regular endometrium, but in general is a suppressive agent, right? It suppresses growth in general, it converts it, right? Whereas estrogen is usually a stimulant, in general. That's like the way we look at it, if the receptors behave in the way they're supposed to.
Correct.
So my perspective on this is that why would you see sort of like a predominantly progesterone perspective in the earlier, less advanced cases? Because the progestin component prevails, so it's kept in check. Once it loses that control, you'll see less progesterone receptors and more estrogen.
I rarely see an estrogen only in any patient.
You rarely see that.
Yes.
But one thing that I think is important for me, at least the way I kind of make that decision, is that I don't know how you feel about, using oral contraceptives or any hormonal treatments, and people use them sometimes. But one thing that's for sure, if you don't see a very good level of progesterone receptors, giving people oral contraceptive is completely, if not harmful, useless.
I agree.
Because you don't have the progesterone receptors. What are you giving oral contraceptives for? You're just feeding estrogen.
Well, again, I don't agree with that concept. I agree that they don't do very well. And one, we're masking symptoms. We're masking symptoms of the bleeding of the uterus.
Well,
You know,
again, I
the
don't agree with
disease
that.
doesn't stop. It doesn't go away when you're on birth control pills, whether there's receptors there or not. I look at it that it maybe
I'm not meaning going away. I'm meaning managing some symptoms, of course. You know, we know it doesn't go away.
Yes,
I'm talking about managing.
and I don't disagree. But I'm talking about the disease itself.
Mhm.
Certainly, it's the ovaries that are major culprit in this disease because why? They produce hormones. So if you suppress function and they're not ovulating, and you give the hormones together, you do see a benefit in symptoms, not in the disease. Because if it was when they cycle, you have 2 weeks of estrogen and 2 weeks of progesterone. In the general population, right? That's the way the ovaries function. And to me, the cyclic manner is that estrogen seems to, for endometriosis, I don't know about anywhere else, but on endometriosis, seems to almost prime the receptors. And when you add progesterone, I think it's almost a negative effect, that it makes the disease grow even more. I don't see any less disease in women on birth control pills than I do with their own hormones. Maybe slightly, but not any significant amount. So to sit there and say, oh, if we give progesterone, the disease is suppressed. No, that's not the case, because how many times have patients been on continuous birth control pills for 10, 15, 30 years, and they have obliterated cul-de-sacs, endometriosis in the bowel, everywhere. You know, if progesterone had a quelling effect in this disease, then the disease would be less, and it's not.
Okay, I just want to take a minute. We have some questions from the, not to interrupt you. We have some questions from our Facebook crowd. The first is, there was a concern about the noise. Dr. Dulemba is actually out celebrating Christmas, so please, let's just be happy that he's celebrating and not in the OR all the time. One of the questions is, if somebody has adenomyosis, and we're going to have a big panel on adenomyosis this year, what is the interplay of hormones with adenomyosis? Because sometimes we think that progesterone is very nourishing to the uterus for people who are suffering from adeno pain. And then if you're saying there are receptor sensitivity to progesterone, what's the interplay there? And then the second question is, what happens if you choose to keep your uterus, but you go into menopause? What kind of symptoms should you expect? So it's two questions for both the doctors.
Dr. Dulemba, please, you know, you're the star of this show.
Well, for one, I mean, I don't treat adenomyosis as a disease entity different. I know that, I think Dr. Vidali, I think you think it's a separate process. I grew up in an era where they called it endometriosis interna, and doctors got confused, and so they called it, instead of endometriosis interna, they called it adenomyosis, lands in the muscle where it doesn't belong. So I think it's the same disease. How do I, you know, if somebody has a uterus, because I remember the last question more than the first question, if somebody has a uterus and they go into menopause, what the symptoms they have to worry about? Well, if you need hormones, and 80% of women in menopause probably need some hormone replacement therapy, then you can take estrogen, you can take it continuously, but you do have to worry about the lining of the uterus. And many years ago, they used to give progesterone with it, and they found that because of the WHI and other studies, that putting estrogen and progesterone together may not be as beneficial as just giving estrogen in a menopausal patient. And so after like every 3 months, again, I don't treat that patient population, but the way I used to do it was every 3 months, I would give like 2 to 3 weeks of progesterone while they continued their estrogen, and do that. And I've heard of some people doing it every 6 months with the progesterone. So
what are symptoms like? What are symptoms like for people who have chosen not to take out the uterus for adenomyosis but go into menopause? I think that's what the question is.
Okay, well, when they go into menopause, if they don't need hormones, then they're probably not going to have many symptoms. If they have menopause and they need hormones, then if there's disease process in there, it may be stimulated by the hormone replacement therapy.
Yeah, so for everybody that's out there watching this, I can speak from personal experience on this. And like all of a sudden, you're as dry as a raisin, and hormones are your new best friend. And so I found it really important that you have to have a good quality excision first so that the hormones are not stimulating the disease. Dr. Vidali, what is your experience in working with adenomyosis, especially because you're do a lot of work with fertility as well?
It's a very, adenomyosis is a huge challenge, I feel. Probably the biggest challenge that I encounter is adenomyosis because, first of all, it frequently coexists with endometriosis. Sometimes it's hard to separate symptoms between what's happening. The endometriosis and the adenomyosis may contribute to the pain symptom in different ways, as well as to the fertility. And the problem is that adenomyosis, for me, the biggest challenge really is minimal adenomyosis, because patients are aware that they have it, and they're like, well, you got to take it out. And I'm like, well, you know, if you're considering fertility, and if you are interested in fertility, you can't just go hunt for a small area of adenomyosis. You end up slicing the uterus and you can't find it sometimes. So that is a big challenge. But we do know, luckily, that after adequate excision, patients with adenomyosis can still conceive and carry successful pregnancy. And sometimes even patients with excessive adenomyosis. I've been shocked so many times where I would see patients with incredible amounts of adenomyosis carry successful pregnancies. So there is actually hope there for these patients if they're managed appropriately, I think, to be successful with fertility. I don't know if you've experienced that, John, but I've seen ridiculous adenomyosis where people successfully conceived and carry pregnancies pretty well.
Yeah, well, Dr. Braverman had shared with me his information on the adenomyosis, because prior to his discussion with me, I wasn't sure if adenomyosis had much impact on pregnancy or not, because I don't deal with the fertility side at all. And so he shared with me because of the inflammatory process and sent me a patient, never been pregnant. She had been tried in vitro, everything. And so she had an adenomyoma. That's, you know, a big glob of it. Plus it was severe elsewhere, and had no pain, came up, and I did surgery. So we took out the adenomyoma because it was a distinct area. And then, you know, she had a obliterated cul-de-sac, endometriosis everywhere. And she went home and had a pregnancy, but loss on her own without even help. And now she has a 1-year-old. And you know, here's a patient that never ever had been pregnant, even with assistance, and then got pregnant on her own when I removed endometriosis and a little bit of adenomyosis because it was in glob. So
I think sometimes, you know, even with the adenomyosis, maybe just debulking, you know, if it's a lot, can be very helpful. You know, these are difficult cases, but, you know, as a general rule, Sally, I personally, even for somebody whose only symptom is pain, I'm adverse to just going directly for hysterectomy. Yeah. I always feel that should, you know, because I feel that hysterectomy, especially somebody who's never had surgery before, I think it's a very, you know, extreme approach. And I feel that excision of endometriosis and potentially, if adenomyosis part of his resectable should be done, a hysterectomy should never be the first option. Because once you do a hysterectomy, the pelvic anatomy changes so much that it changes completely everything in the pelvis, I feel. And so, like, it should always be kind of a radical, kind of a last approach. I feel that's pretty much, and, you know, of course, it's a generic thing. There's different exceptions and everything else. But in general, I feel that you know, the changes to the pelvis that happen with a hysterectomy are very radical for patients.
Right. So I'm a pelvic physical therapist.
Wait, I do have a question for Dr. Vidali. I just actually, there's a doctor in Japan. I don't know. I can't remember his name.
Rosada, of course. I do that operation.
Oh, do you really?
I do, yes, of course. I contacted Dr. Rosado. He's retired, but I communicated with him before I started doing the procedure, and I do the procedure, but I reserve it for patients who, it's a difficult procedure, and it causes a lot of bleeding, and so I reserve it for patients for extreme cases, because it's kind of an
Can you
extreme
share that
approach.
with people that might be listening? Because I know the surgery, what you're talking about, but they may not.
Yeah, I have video. I should actually, it's funny because I should make a video of it. I have video of the procedure actually. And,
I didn't think anybody in the U.S. was doing it.
yeah,
There's another doctor also.
Dr. Sherman stopped doing it, to my knowledge.
Was he the one in St. Louis?
Yeah, he had a video and
yeah,
then he stopped doing it. And I was like, I guess he had these reasons. But it's tough though, because obviously it's a big surgery and the patient needs to be aware it's a big operation. It's going to be a laparotomy most likely, you know, with bleeding and the uterus is reconstructed. So there's a risk, even in the largest Japanese series, it's a very, you know, it's a high risk of uterine rupture. So this is a very extreme procedure, John. So I do it in very, very selected cases.
Okay.
What's interesting to me, and I saw somebody, I did surgery on somebody last week, is that much literature on adenomyosis comes out of China and Japan. So, and most of the patients with the most severe adenomyosis I've seen are of Asian ancestry. So it is, I have always wondered, and it's a very small, it's an observation that I have, I may be wrong, but maybe it's just a wrong impression because I don't have any statistical evidence, but that it seems to be more frequent in patients of Asian you know, ancestry. I don't know if that's.
Let me make a comment about that. A good friend of mine was the director of the minimally invasive program in Singapore, Chinese. There's over 90% Chinese in Singapore, and you might even know him, Peter Barton Smith from the UK.
Yeah, of course, I know Barton Smith. Yeah. I send him patients in London all the time.
Yeah, I was in his wedding.
Very good doctor. Yeah.
Very good, very good. And so he was sharing with me, because he's now back in London, but he was in Singapore, that he thinks the disease in Asians may be different because he said they have not as much pain. They have huge fibroids, severe disease, and very little pain. And I thought maybe it was cultural. And he goes, no, they have pain for other things. But for the disease of endometriosis, it was severe. So that kind of goes along with your adenomyosis aspect.
You know, Sally, this is something we should consider because to my knowledge, I don't think there's, are you aware, Sally, of any studies looking at racial distribution of endometriosis in terms of disease severity? Is there any of that?
I am not aware of anything currently. I do know, like, I can't cite the research exactly, but the last research that I read is one of the reasons why endometriosis is such an international health crisis is that it knows no boundaries.
That's
so
exactly
it's not right. So it's not, it's the research that I've read is it's not worse, but that doesn't mean it's current research. We have two questions, one of which is, what do you do about adhesion? Which is right up Dr. Dulemba's alley. And then I'll ask the other question after we talk about that a little bit. And here's the thing, and you may have different opinions, and I have an opinion as a physical therapist, but Dr. Vidali might not believe how much pain adhesions cause. So, like, do you think adhesions cause pain, and what do you do about them?
Well,
PT could have an opinion later.
Okay, well, to begin with, general surgeons are often taught that adhesions do not cause pain unless there's complete or partial bowel obstruction. Now, I've argued with some, and they do concede that the pelvis is a little bit different, but I still think bowel pain is excruciating because there's a lot of sensory nerves in the surface of the bowel. Now, in my opinion, I think adhesions are probably as much, if not more, probably more of a problem than endometriosis, because endometriosis is abnormal. Adhesions, sadly, are a normal healing process of the body. Your body doesn't know good from bad healing. So, and what I think that I've seen, of course, I don't do a lot of studies. I'm just too lazy to do studies. But it seems like endometriosis in the early stages is very cyclic. And then it seems like the symptoms get worse and worse and worse as the disease progresses. But my opinion on what's progressing, making the disease or the pain all the time, it's adhesions, because organs become stuck to each other. I am so focused on it that when I see patients with ovaries that are stuck to the pelvic sidewall, they sometimes have hip pain. Of course, they go to get evaluated, and their hips are fine, but they have hip pain. It's just that pain from organs stuck is worse. And of course, if you cut adhesions, what happens? They grow back. So this came out of Janssen from, I can't remember the year, out of the Scandinavian countries. And of course, Dr. Krasinski in Germany does it. But I offer second look surgeries because the healing process starts the instant you're healed, or instant you're injured. And the healing takes 6 months to complete. But the primary healing is in the first week and a half. So there's like red blood cells, there's platelets, you make some blood clots, fibrin, fibrinogen, and it's a whole cascade of events in that first week and a half. So the theory is that if you potentially interrupt that healing process, that you may not get the same healing cascade because you've interrupted it. So I've introduced what's called second look surgeries into my options. Now, patients have to decide because the success rate is only about 70%. Now, when I do the second looks, only about 80% of the patients have adhesions. This 20% don't. And I'm sure it's genetics and things like that. Could it be surgical technique? Yeah, but it's the same surgeon. So, you know, I don't know who's going to have adhesions, who doesn't. But out of 80% that get adhesions, the studies show 70% do not get adhesions when you interrupt them. Of course, I use heated humidified carbon dioxide. Why? Because I don't want the non-surgical areas to get dry. I mean, hold your eye down for like a couple hours and it's going to be, you dry out the peritoneum, the diaphragm, the rest of the bowel, and surfaces you don't operate on, and it may get dried and may be a source of adhesions. Certainly, I think the technique of the robot is very accurate and precise. And then I use a barrier. I've been using amniotic tissue, and then the second look. And I can boost my success rate to the mid-70s. I don't like to ever say it's higher than that because the body's going to heal in spite of what I do to it. A long thumbnail sketch.
So I'm just going to interject. Thanks. So I'm going to tell everybody out there who is interested in purchasing an Endometriosis Summit ticket that you will get to try that heated air in our exhibit hall,
Okay.
which should be really cool because a lot of the patients don't understand that. They don't understand.
Is that the InstaFlow?
Yeah, how that affects. So we should have that there for you. The other thing I'll say is I'm a pelvic floor physical therapist. I'm a pelvic PT. I specialize only in endometriosis. And this is a common case that I have every week. They go somewhere to an excision specialist that they find on Nancy's Nook. By the way, Nancy is greeting us at the Endometriosis Summit in case you don't know yet. And they go somewhere to a Nook specialist. They come back and they say, I still have pain, or they come back to me 2 years later, I still have pain. I must need a hysterectomy. It must be adenomyosis. And so my thing is, yes, adhesions are there. And yes, there are cases where they cause pain. But oftentimes, I almost always find something wrong with the hip. And I almost always, I would say at this point, I find hernias against the pelvic nerves a ton of times, which is far easier to fix than an adhesion. I find a ton of weakness in the core, and I find a lot of different issues, even from how they're connecting and coordinating their bowel and how they're connecting and coordinating their diaphragm. And so I wish that patients would embrace using some complementary therapies, even if it's before they run in and assume it's adhesion. I had a surgery, then it was a Nook specialist, then I still don't feel well. It's either adeno or adhesions. And that's really not true. And my experience also personally is there's a lot of other stuff that goes wrong in the body. And before we assume it's one of something that's harder to treat, we should back up and widen the lens a little.
A couple things. Yeah. Before Dr. Vidali jumps in. one is, say somebody has had surgery with a NOOC specialist or an endometriosis specialist. It doesn't have to be NOOC. But if it's adhesions, oftentimes you see symptoms within 3 to 6 months. Okay, because the adhesions are starting to organize, starting to get more blood vessels, more nerve endings. And then the symptoms continually get worse. But I'm not saying that it can't be muscle, that it can't be bone, it can't be, I'm just saying that when you cut out tissue, the body has to heal. It has to heal.
Yeah.
There's no ifs, ands, or buts.
Right. I totally agree with that. But I also, you know, it becomes like, that's why you need I know Casey Burnett talked about, we need multidisciplinary care.
Great.
Because the other thing is about that 3 to 6 month range, if you have something like bladder driven pain or a nerve compression, central nervous system, or pelvic floor dysfunction, you've now healed from surgery and you're going to start feeling the pain that's left behind because it's not fixable by surgery. So it
I don't
becomes
disagree.
dance, and you have to find somebody that understands the role of adhesions and how to evaluate for that, and find somebody who understands how to evaluate, and everybody needs to work together.
That's why my visit is 2 hours long, because I talk about all of that. I talk about intestines, the bladder, the nerves, the adhesions, the pelvic floor dysfunction, infection, including things like Lyme's disease and small intestinal bacterial overgrowth. So
Right.
That's why it's so hard to make an appointment with Dr. Dulemba. He spends 2 hours with every patient.
I know.
I do.
I try to send him a patient. They say, end of January.
No, I did get her in.
No, thank you.
So another question is how Dr. Dulemba's meal is arriving. So we're going to have to
we're fine. We're fine.
Another one of the questions is about bowel endometriosis. And if somebody has bowel pain, but they haven't had a diagnostic lab, what are the signs and symptoms? I know Dr. Dulemba and Dr. Vidali are going to sit on a panel that's going to talk very explicitly about bowel endometriosis, but what are some of the signs and symptoms of bowel endometriosis?
Please, Dr. Dulemba.
Okay. So. Well, the two that really play a role with me are loose and or painful bowel movements with their periods. I mean, to me, that's almost definitive for endometriosis on, in, or near the bowel. Certainly, you can have blood in your stool. That doesn't always indicate that there's endometriosis eroding into the bowel, but that's one of the things that you have to consider. Of course, pain, when there's things pulling the bowel, like adhesions, because they're stuck. It's almost like a hairpin turn, and trying to get stool through some of their, that area is painful. Some patients have nausea, but that doesn't always necessarily mean bowel involvement. That could be their response to pain or other issues, you know, hiatal hernias, everything. So to me, loose and or painful bowel movements are sine qua non for bowel endometriosis. Do you see anything differently, Dr. Vidali?
I would like to add that I often, patients report generalized gastrointestinal symptoms, because endometriosis is not a local disease only.
I agree.
Your body's fighting inflammation, which may happen to be mostly in your pelvis, but your body's fighting a battle. So I observe that people sometimes describe general gastrointestinal symptoms. You know, clearly, you know, what you describe, which is painful defecation, like to use common terms, it hurts when you poop, especially when you have your period. But I see generalized symptoms because the body is fighting a battle, and you get this generalized GI dyspepsia, eating, and a lot of the patients on their own adjust their diet sometimes just to actually get through the day. They end up on their own going gluten-free, dairy-free, just because they're trying desperately to try to see. They can't eat anything. They only eat certain things. I don't know. You want to comment on that, Sally? I see people like restricting their diet because they can't eat anything.
First of all, I live that life. I know I have celiac, but I live the life. I can't have quinoa. I can't have sweet potato. I can't have this. I can't have that. Because I went so many years with such extensive bowel disease.
And nobody told you, right? You figured it out on your own.
Nobody, I figured that out on my own. So I'm old now. I've been gluten-free for over 20 years. Nobody did it years ago. But the other thing is that what I see is the patient comes in, and I see this a lot in my young, like early 20s, who are trying to make their way in the world, trying to build their lives, finish school, you know, meet someone if they want, have a career. And they come in and they pick up their shirt and they go, I'm bloated, I'm bloated, I'm bloated. I tried this diet, I'm keto, I'm paleo, I'm gluten-free, I'm dairy-free. And I see that a lot. And then ultimately, the other thing I see is they just almost cry from the endo belly. I have this belly, I have that, you know, and I see them improve greatly with excision. They almost always, if you have bowel endo, I believe you need pelvic PT, because there's a spasm in the muscles that wrap around the bowel. Once you've taken out the disease, you have to learn how to poop again. And then the other thing that I see is sometimes they need a functional nutrition involvement, because they have to get nutrients somehow.
Yeah, I mean, I see people who follow very restrictive diets, I mean, on their own. They can't eat anything. It's like really extreme, I would say.
Right. I want to share a story with you on a patient of mine that's 15, was 15. She's now like 27, 28. Because she had bowel symptoms. And of course, I urged them to get a colonoscopy and an endoscopy. And it turns out, not only did she have endometriosis, but she had Crohn's disease. And after the surgery, she felt pretty good. And when Crohn's under control, she has no symptoms. When she doesn't, she has pelvic pain, because there's 30 feet of intestines. And Crohn's disease can be from your mouth to your anus. So you have to have an endoscopy along with a colonoscopy. And so if she hadn't had the Crohn's disease diagnosis, we might have ended up having her with more surgeries.
Yeah.
So the bowel plays a huge role. And again, it's not always endometriosis.
Well, it's because of the whole autoimmune picture, of which, you know,
Bingo.
we'll talk
Yeah.
more. And, you know, Sally, as
Yeah.
you know, we're going to have, I'm going to talk a little bit about the autoimmunity and endometriosis in the Braverman Memorial Lecture. But I would like to say that everything, when you talk about the body and the immune system, each one problem adds to the other. That's why sometimes diets lowers inflammation, you lower that. Endometriosis, you know, kind of like lowers the barrier for other autoimmune diseases to happen, because your body is fighting a battle. So I think that's sort of like, and we could discuss this in another live webinar, Sally.
Well, we may not do them every week, but we do plan to continue the webinars. I'll also say, if you look at the current research, the need to change gut health usually involves some component of exercise. So if our endometriosis people feel too ill to exercise, then taking all the collagen, changing their diets, and doing the surgery may not do enough to heal their gut. And so it's really important to look at the whole picture. Before we go, Dr. Dulemba, I want you to talk about 2 things you're going to bring to our town meeting in Hoboken, and then we're going to ask Dr. Vidali the same question.
Okay. Anything about the Steelers?
We can't wait.
Anything about the Steelers, right?
First of all, the 2 of them are definitely going to have a Who Wore It Better contest. Dr. Vidali has his fringed jacket, and Dr. Dulemba has been collecting his Steelers gear for over a year. So yes, 2 things you're going to bring to our panels at the town meeting from each of you.
Okay. All right. Do them now?
Yes, now.
Oh, 2 things. Oh my gosh. Okay. Well, different than the things we've already talked about, or similar, or along the same line?
Whatever you want, Dr. Dulemba.
Okay. For one, I do have another theory on bloating and endobelly. Okay. Because there's some patients, and I'm not saying every single patient, but this one kind of makes a little sense. And I've actually seen my theory work. And it's because I grew up in an all-Italian neighborhood. And I'll share that with you. So my theory on bloating, because some of the patients that I see, they wake up in the morning and they don't have much of an abdomen swollen. Their belly seems to be fine. They eat or they move or they drink, and all of a sudden, in the next 45 minutes to an hour, they're bloated, no matter what they eat. Now, some can decrease it a little bit. And I sit there, and in my mind, I'm like, wait a minute. How can endometriosis itself be causing this by what they're eating? Are they absorbing it that quickly in 45 minutes to an hour to have that much of an impact to make you bloat? So my theory is, again, back to adhesions. Okay, so I grew up, as I said, in an all-Italian neighborhood, and all of my family's parents, or I take it back, my friends' parents made wine in their basement. My dad didn't, because back then it was illegal to make wine in your basement. Now, no, that was not prohibition. I'm old, but not that old. That was the 1920s, okay? Now, but up until 1978, it was illegal to make wine in your basement. So they had Dago Red and Dago White, big vats. Some of the vats were huge. And when we were young teens, we would sneak down there. We would scoop it and drink it and think we were getting drunk, and we probably weren't. It was probably just fizzy grape juice. But we would stagger around. One of the things that I found fascinating, and it's still stuck in my mind, is that when we walked by the vats, bumped the vats, or scooped the vat, it would bubble, the fermentation, okay? So I'm sitting there, and this is back in the 90s. All of a sudden, I'm doing surgery. It was only laparoscopic surgery. And I'm watching the intestines, and they start to peristalse, okay? When you eat or drink, there's a thing called mass effect, and it's a synchronized movement of your intestines or exercise, and they start with small bowel and work all the way down to the large bowel. And I actually saw my theory in action 3.5 years ago in Nigeria. So it was, so I'm sitting there and I'm going, wait a minute. In the large bowel, there's fermentation. And if you have adhesions and the bowel is stuck and that part is starting to squeeze, it can't squeeze and peristalse in a normal manner. And so it's just going to sit there and stir up the fermentation the same as I would when I was scooping up the grapes. But what would happen is, instead of moving it in a nice uniform manner, it's just sitting there stirring it up. And that's why 45 minutes to an hour after. So here I am in Nigeria, and I'm sharing this with somebody across from me who had already had a bowel resection, and she couldn't even eat because the pain was so severe. And I told her my theory. She was like 6'3" and about the size of my finger. And she has this tight blouse on. She starts to eat, and I'm watching her transverse colon start to peristalse, and there goes the bloating. That's my theory. When you cut the adhesions, they don't seem to bloat anymore. Now, I'm not saying that that's the case in every case, but I think that plays a huge role in endobelly when I'm sitting here going, wait a minute, how can that much inflammation occur by drinking something or eating something and have it happen that quickly, even if they're doing a gluten-free diet? That's my...
Well, we're going to discuss endobelly on Saturday at the Endometriosis Summit workshop. And we will also discuss it not only in your panel in the morning, but in the afternoon. It will be part of our case studies on our pelvic pain panel, because now consider the bowel peristalsis and the fermentation from that. And if you throw in a little SIBO and a little pelvic floor dysfunction, how involved it'll really be. Dr. Vidali, what is something you're going to bring to our town meeting?
First of all, I'd like to tell Dr. Dulemba that I'm not going to hold it against him that he's Italian, okay? And we're going to talk about, I think it's going to be, we're going to have some very innovative ideas. We're going to talk about immunology and the role of immunology in the ontogenesis, in the evolution of endometriosis, and especially its role in also as well in not just in pain with associated autoimmune diseases. And let's remember, association is not causation, but association, as well as, of course, pregnancy loss, which is a huge problem, and pregnancy complications, as well as infertility.
Sure.
So I guess we
Awesome.
can, that's a lot. That's a lot.
So I'm going to add that we are going to join the patient voice to all of this so that the patient leaves empowered.
Okay.
And Dr. Vidali and I are going to host a fireside chat with Nancy Peterson in a public appearance. So she will not be behind your computer screen.
No way. Oh,
Yeah,
wow.
and it's going to be awesome. So tickets are on sale.
Very exciting.
www.theendometriosissummit.com. And I hope throughout the year that Dr. Dulemba will come back and join us, perhaps not in the middle of this dinner, but
Well, it
sorry
was
about
a
that,
Christmas
Dr.
thing.
Italian dinner, Italian dinner.
Yeah.
Well, I've got
And then-
5 daughters, and so that's the only time we can get everybody together. And they said 23rd. I said, sure, that's fine. And all of a sudden, today, I'm
Right.
like, oh my gosh,
We
that's
will
the same
also
day.
be joined next week by Neva Herzig to discuss the role of physical therapy and sex. Our Endometriosis Summit will have a big panel on sex and relationships, and we're going to make everybody in the audience get involved. So you wait and see what we have in store for you. That's all the time we have for you on Facebook tonight. We will share the live recording, and I hope to see you all again.
And thank you, Sally, for everything you're doing.
Thank you, Sally. Thank you, Dr. Vidali.
Thank you. Bye,
And
John.
I'll see you guys
Bye,
see you at
everybody.
the end of February. Bye-bye.
Bye-bye.
Bye.
Okay, so we're done
You're
live.
still recording? Are you off?
I
Are
have
you
to
off?
get the, no, you have to,
Leave me? Okay, we're good.
wait, yes.